The purpose of this presentation is to determine the best management strategy for idiopathic toe walking, which is based on recent evidence. This will be achieved by searching relevant databases, finding studies of the highest possible quality, appraising the studies, and then based on the studies, developing one conclusion that can be applied to practice. With our PICO question, P was paediatric or children, I was all available treatment modalities, C was no treatment or another treatment modality, and O was complete or partial reduction in idiopathic toe walking. When these components are put together, our question was, within the paediatric population, does one or multiple treatment modalities lead to long-term complete or partial reduction in idiopathic toe walking? For our search strategy, we search the following search engines: Medline, ProQuest, Senile Health, Senile, Ovid, Informa Health, PubMed, and Cochrane. Medline yielded no results, and Cochrane had some of the articles which had already been found. Search terms used were children, child, child with truncation, paediatric, paed with truncation, toe walk with truncation, idiopathic, and treatment. We also used Boolean operators such as and or. The use of wildcards was not necessary for our search strategy, as there were no alternative ways for spelling our key search terms. Only one search was refined with limitations. All other searches resulted in a small pooling of articles which were easily filtered through. If limitations were needed, changing the date range, limiting to English-only articles, and limiting to randomised control trials or systematic reviews would have been considered. Here is one of our search strategies with EBSCO as a chosen database. We entered the following search terms individually: child with truncation, paediatric, idiopathic toe walking, and treatment. This left us with over 300,000 articles. Then, using OR, we combined paediatric and child with truncation. This left us with over 300,000 articles still. Then, using AND, we combined idiopathic toe walking, treatment, and the previously combined search terms, which left us with 8 articles. We appraised a total of 4 articles using Pedro scale and CEBM critical appraisal tool. Interpretation of randomised control trials was achieved by using the display scale. Interpretation of the systematic review was achieved by reviewing study methodology that included trials and whether or not the reviews were homogeneous.
Okay, so the first systematic review that we appraised was Van Bemmel, 2014, to compare CAST and operative treatment of children with idiopathic toe walking or equinus contracture. So results showed that ankle dorsiflexion significantly increased 3.1 degrees after 3 years post-CAST treatment, and significantly increased 14.2 degrees after 3.3 years post-surgery. No statistical significant difference between groups in persistent toe walking and complications after treatment. The conclusions were that there are favourable results for using surgical treatment over casting in children with ankle equinus but not in persistent toe walking. Due to heterogeneity, there are no firm conclusions, and there is need for more prospective randomised control trials with homogeneity. So we appraised this study using CEBM, and it scored 5 out of 6. We decided the judgment was fair quality because of heterogeneity in patient sample and length of follow-up time. The study only used retrospective studies, and outcome measures differed. Pre-treatment, patients who had surgical intervention had more severe ankle equinus than those who received casting, which could have influenced the results. This study included patients who only had ankle equinus rather than idiopathic toe walking. Although this systematic review was methodologically correct, we cannot make firm conclusions due to heterogeneity.
The second article we appraised was by Van Kujic and colleagues 2014, which conducted a systematic review with the aim of assessing the effects of the currently available treatment options for patients with idiopathic toe walking. Outcome measures include ankle range of motion, parental perception, and gait analysis. Results for serial casting show that there was discrepancies among included studies. Engström and colleagues 2013 showed short-term benefits of improved ankle dorsiflexion and gait analysis. However, Hirsch and Wagner 2004 and Stricker and Angelo 1998 concluded that conservative methods led to no improvements. In addition, Katz 1984 found that ankle dorsiflexion decreased by 6 degrees 2 years after treatment. Results for surgery showed that there were improvements in gait and ankle dorsiflexion. However, the extent of improvement remains heterogeneous. The observed changes included an increased ankle dorsiflexion at initial contact 1 year after treatment. Children developed first rocker, knee flexion increased, and hyperextension reduced. Despite these improvements, normalization did not occur. Parental perception demonstrated a possible placebo effect for no intervention and serial casting, where Eastwood and colleagues 2000 found that 50% of parents reported improvements, despite only 6% of the observed patients in no intervention group and 10% in the serial casting group showing complete resolution. In conclusion, there is limited evidence for serial casting and surgery, but both serial casting and surgery appear to improve ankle dorsiflexion and gait patterns. However, there are no long-term effects lasting more than 1 year. However, there is little evidence documenting the results of surgery many years after the procedure. Therefore, further research is needed to identify the best treatment modality. Large-scale trials and longitudinal studies should be considered. This review scored 4 out of 6 using CEBBM and was considered fair quality. While the study was of good methodological quality, 18 of the 19 included trials were considered low-level studies, subjected to bias with differing outcome measures, treatment modalities, and follow-up periods. All these factors led to heterogeneous results and reduced the overall quality of the review. The results of this trial should be interpreted with caution.
So we appraised an RCT by Heron 2015, which compared carbon foot-plated orthoses versus ankle-foot orthoses in the treatment of idiopathic toe walking. Results showed that 9 participants were analysed in each group. Both groups showed significant improvement in kinematics versus baseline whilst wearing the orthoses after 6 weeks. Participants in the AFO group walked significantly faster and heel rise times significantly improved when compared to those in the foot orthoses group after 6 weeks whilst wearing the orthoses. When the orthoses were removed and children were wearing shoes only, the AFO group could not sustain the improvement and reverted back to toe walking. Foot orthoses group, however, did sustain improvement. Significantly more parents felt donning the foot orthoses was easier. So the conclusions were AFOs control idiopathic toe walking whilst children are wearing them, but subjects may revert to earlier walking patterns when they are removed. Foot orthoses do not control idiopathic toe walking as well as AFOs whilst wearing them, but the orthoses, once removed, sustain improvement of gait. Foot orthoses are less restrictive and more accepted by parents and children. So we appraised this article using the Pedro scale. It scored 7 out of 10, but we said it was good quality and valid because even though it got 7 out of 10, it lost 3 marks due to subjects, therapists, and administrators not being blinded. For these interventions, this could not be avoided. Still need to consider the small sample size, and the study population was a broad range, 3 to 8 years.
Engstrom 2013 conducted a randomised control trial where the aim was to test the hypothesis that combined treatment of serial casting and botulinum toxin A is more effective than casting alone in the treatment of idiopathic toe walking for patients between the ages of 5 to 15. Outcome measures were severity of toe walking, parental perception, and ankle range of motion. At baseline, the treatment groups were similar. The results showed that at 12 months post-treatment, the results showed no statistically significant difference between the combined treatment group and the casting alone group in all outcomes. However, both groups showed improvements in severity of toe walking and ankle range of motion. The article concludes that there is still much discrepancy within current available literature. Further research is needed investigating injection therapies, additions of bracing, or more vigorous conservative methods, which can either be trialled individually or in combination with one another. Using the Pedro scale, this article scored 8 out of 10. The first criterion which was not met was blinding of all therapists. This could not be achieved due to the nature of the trial where one group was injected and the other was not. The second criterion which was not met was measuring 80% of the group with at least one key outcome. This would have been met had 5 participants not dropped out of the same group. So because the majority of the criterion had been met and most of the criteria between 2 to 8 demonstrated a lack of bias, this article was considered good quality and reliable.
Okay, so as you can see, we have summarised the studies looking at the treatment of idiopathic toe walking. There are level 2 studies for serial casting, surgery, and foot orthoses. Other treatment regimes consist of lower level studies. We also found 2 literature reviews on this subject but decided not to include them because they were not part of the NHMRC hierarchy. There is still uncertainty regarding the natural history of walking. However, it is believed that adults who toe walked as a child do not maintain the condition or severity in later years. Treatment should only be considered if parents or child are troubled by the condition in terms of appearance, pain, interruption of activities. Currently, there is mostly lower level studies regarding the treatment of this condition, and there is discrepancies among trials. Therefore, treatment is difficult to determine. At the moment, the highest level of evidence, which is still only level 2, is for surgery and serial casting. However, this is for only improving ankle dorsiflexion rather than conclusions about toe walking. There was a systematic review on these treatments, but due to heterogeneity, no firm conclusions could be drawn. Even though these treatments have the highest level of evidence, I would only reserve them for persistent severe cases who have significantly reduced dorsiflexion. This is because surgery is a very invasive procedure and can be a traumatic experience for the child. It would also be an expensive option for parents, as well as considering recovery time of the procedure. Similarly, casting is also an invasive procedure for the child. There is time lost by parents taking the child to be cast and recast, as well as being expensive. It is also difficult in regard to bathing, as the cast cannot get wet. The cast might be uncomfortable for the child and lead to rubbing, itchiness, and pain. Parents may not want their child to look like they have something wrong with them, as it's a very visual treatment. Children can wear casts up to 6 weeks, which is a long time taking into account the negative aspects of casting. Weighing up the pros and cons, I would choose surgery over casting due to favourable results and less complications. Furthermore, there is high evidence, level 2, in favour of carbon plate foot orthoses in improving idiopathic toe walking in the short term. They would be less expensive than casting or surgery and less invasive. They are easy to put on and does not change the appearance of the child. Foot orthoses have favourable results compared to AFOs and are less bulky. Therefore, as a podiatrist, if I diagnose a child with idiopathic toe walking, I would treat conservatively first by monitoring condition due to limited high quality evidence of treatment. The main thing would be to manage parents' expectations, explain to them why you have not given them the treatment due to lack of evidence, therefore you don't want them to spend unnecessary money or put child under stress. I would reassure the child's condition would be monitored, but will most likely resolve itself, therefore a wait and see option is most appropriate initially. After 6 months, if the toe walking is still severe or painful and the parents are still worried about it, I would try carbon plate foot orthoses. But again, manage expectations of parents, saying there is some evidence for this, but not in the long term, and there is a chance that this might not work. So they need to consider cost as opposed to no treatment and the likelihood of improvement. I would only suggest surgery in persistent cases with severely reduced ankle dorsiflexion because of the invasive nature of the treatment. There is need for prospective longitudinal randomized controlled trials conducted in relation to the treatment of this condition.